Hello everybody, I'm Dr. Fuad Khan. I'm a psychiatrist. Today I have for you a presentation that I've developed for my colleagues who work in the emergency department in hospital floors, managing a wide variety of patients who have challenging behaviors. You know, times are tough, resources are limited. A lot of funding cuts, stigma, and other reasons have led to a state in our country where we're just playing a catch-up game, trying to meet the ends and trying to meet the needs of our patients. In such situations, every attention we can pay to improving our skills is just paramount. So I'd like to thank my colleagues, and I feel honored that they put a trust in me to put together this presentation. So let's go and have a little discussion about our today's topic. Today we are going to talk about managing agitated and aggressive patients. This is relevant to any setting but focused primarily at emergency rooms or patients who are admitted to inpatient floors. Such patients can be challenging because they are at risk of injuring staff, hurting themselves, disturbing the milieu, and damaging property. Now, clinical teams end up with a reaction as well at times. Fear, anxiety, avoidance, and developing judgments and biases happens and can further lead to inadequate care and worsens the safety situation. In such scenarios, multifaceted challenges are present. As we all know, the clinical picture dominates the scene, but there's other considerations. The experience and skill level and confidence of all staff, administrative supports or lack of resources, clarity on legal and ethical matters, and the ability to document and justify management appropriately are all very important considerations. Now let's go and discuss types of agitated patients. In general, we can block them out into 3 clusters for presentation and 3 clusters based on etiology. Now that's a very simplistic approach, but we're talking practicality here. So let's look at the first group. The presentation is of the delirious or the confused type in such patients. The second group is more psychotic, anxious, often called nervous breakdown type. The third one is the interpersonally challenging one, the demanding, the manipulative type. For etiology, we must remember that the cause is almost always multifactorial. Even long wait times can contribute to agitation. For the scope of our discussion, our 3 major clusters would be the medical causes, such as these, often more going towards delirium. And then we have the cluster of substance-related causes, which is either a mix of delirium or paranoid or manic states. We can divide them generally into 2 major subgroups, the intoxication and the withdrawal group. Now remember, we are including substances that are illicit or medications that were prescribed. The third group has an etiology that lies in a psychiatric illness, such as psychosis, the anxiety type, and the personality type. Before we move on, let's have a quick word on the excited delirium syndrome. Excited delirium syndrome is not a DSM diagnosis, but the American College of Emergency Physicians recognizes it. It is important to know a bit about it because it is a severe issue in patients' behavior-wise, as well as an important management problem. There's a high risk of injury, there's a high risk of medical compromise. Such patients can wreak havoc, exhaust themselves, and receive large amounts of sedatives that may even get to a point where they may need respiratory support. Its hallmarks are bizarre presentation with untiring superhuman strength, superhuman stamina, aggression, severe paranoia, and significant insensitivity to pain. They have intense autonomic arousal and can have strange behaviors such as aggression towards shiny or glass-like objects. There is no standard treatment for that, but medications such as benzodiazepines and haloperidol have been commonly used with reasonable success. Sometimes even ketamine has been used. Let's talk about approaching agitated patients. Step number 1 is that we need to work as a team. All disciplines must get together quickly, clarify the approach, and may continue to do that periodically during the whole operation, all the way through the duration of the patient's aggressive state. Teamwork is key to success. I recommend that even after you've debriefed and are looking at the videos or other things, you should always look at all team players having been present and delivered their responsibility. Now, during these quick debriefs or huddles, the following 5 topics must be specifically addressed. Number 1, assessment. Who's going to assess? Who stands by? Who gets supporting data? And how are we going to rate the overall level of agitation? There's many ways to rate it. Simple language to say mild, moderate, severe, or extremely severe is fine, but a validated tool is best. It is the most appropriate way to develop a perspective, guide, and justify your management. We recommend BVC, Brosset Violence Checklist, since it has a reasonable predictive value for imminent violence. Anybody scoring more than 2 items on the 6-item scale has a 50% chance of violence in the next 24 hours. As for me, a score of greater than 2 and rising is a reason to treat immediately. There's some other tools as well, and you can see their names here. They include BARS, SAT, and PANSS, the excited component one. The second most important part is prediction, and everybody in the team needs to know what, as a clinician, you are predicting. Predicting is like prognosis and part of skill. It will put you in a clear position, and a sense of clarity and readiness will ensue. Prediction can be done simply based on the past history of violence and the very recent aggression, such as a police brawl. Now, a subset of predictability actually is unpredictability. A history of unpredictable severe aggression where you cannot find out what provoked the patient is extremely concerning. These patients must be treated very aggressively since you can never find out what was the external reason that got them going. PCP, meth, and severe paranoid psychosis are at risk of such unpredictable violence. This information is vital and can be used to decide and justify the medication, the treatment, and even if it included secluding or restraining them. Other intoxications, cognitive limitations such as in dementia or intellectual disability can also increase the chance of violence. All team members must know what they're facing and what can potentially go wrong as part of prediction. Number 3, engaging and de-escalating. This is a full topic and I won't discuss it in detail, but it requires a skill of knowing when to de-escalate, how to de-escalate, and when it is ineffective. Concepts of trauma-informed care increase the likelihood of the de-escalating team remaining empathic and handling everything effectively because they see aggression as a distress signal rather than a deliberate aggression and a wish to attack on the part of patient, and that protects the team to not retaliate incorrectly. The fourth important part of the huddle would be a word about medical management. Everybody should be very clear that we are both treating a symptom as well as we're treating the etiology. The whole team, including some of the non-clinical members such as security, should have some basic idea of what we are approaching and how we are approaching in terms of medical management. Then comes the last part, which is number 5, physical management. So apart from selecting location, ambience, and surroundings, a clarity and quick discussion about various options must be undertaken. What if scenarios must be considered? What will happen that the team will change their approach should be discussed. Now, before I go on to discuss medical management, let's talk about 3 important clarifications. Number 1, engagement, a prerequisite to de-escalation. If the patient can reduce behavior and increase conversation, you possibly have engagement. This must be reflected in your documentation. It is important to make a decision to treat immediately once a reasonable attempt at engagement has failed. Number 2 clarification, chemical restraints. This is a word often incorrectly used. Many people mix up chemical restraints and treatment. There's a clear difference. if you have a patient with schizophrenia presenting with acute paranoid psychosis and you give him a treatment with an antipsychotic, you're basically using a medication that is indicated for such a symptom, such an etiology, and will be considered a treatment. So this is not a chemical restraint, it is a treatment. However, let's say you tried giving them the antipsychotic, it didn't work, you did it again and it didn't work, and the patient is continuously aggressive. In that situation, you decide you're going to give them a large dose of Versed or Precedex or Propofol to calm the patient down. So you're now trying to use it to sedate, discipline, or immobilize the patient. This is chemical restraints. So chemical restraints are generally uncommon, and their rationale is often that the actual treatment did not achieve results, or the treatment with the right medication was not possible, let's say because of you not knowing what the patient might have ingested. Clarification number 3, quiet time versus seclusion. Quiet time is a great option to offer to patients. It means that they can go into a locked room, but on their own accord, and they do have the option to request to come out. In other words, patient controls. Seclusion is different. It's involuntary and requires to be ordered or discontinued by a provider. Now let's talk about medications for management. Remember, medication approach is one part of the multifaceted approach. Now we'll look at the various classes, routes, and indications and keep the discussion to being practical rather than a comprehensive academic discourse. Our main medication classes are 2, benzodiazepines and antipsychotics. But there should be a deliberate effort to make sure we do not ignore other options such as mood stabilizers, medications often called comfort meds, medications for opiate withdrawal support, and those that may be used as chemical restraints. Now, let's discuss some important principles of medication management, and I will divide them into 2 major groups. Route selection. You have these routes available. The best is when patient participates and you can give oral meds. If you suspect potential for cheeking or spitting out, use the orally disintegrating medications. For example, olanzapine comes as a wafer called Zyprexa. Risperidone comes as MTAB, and aripiprazole as Abilify disc melt. Remember, the time to action, or Tmax, is the same for regular tabs or orally disintegrating tabs. They do not produce the effect any faster. Now, for faster effect, you need IM medications, and the indication is severe symptoms and or significant patient distress that can result in behaviors. Inhalational routes are available, and they're relatively new in their use. For example, loxapine inhaled or midazolam intranasal, they can be used, but they do require a setting where a certain bronchospasm can be effectively treated should it happen. Now, the second important principle is selecting the right dose. I have often seen that many providers make a mistake. They select doses in an emergency setting as if they were working with a patient in an outpatient setting. Typically, in an outpatient setting where the patient will be out of your sight, you would like to start low and go slow. However, in an emergency setting with aggression and agitation, your target is to stabilize the emergency quickly and effectively. In this situation, you should start to think about using the highest indicated dose that you can safely give to bring the situation in control quickly. There are multiple clinical reasons for this. First of all, the patient is in distress and is reacting behaviorally. It's not a patient in an outpatient setting who's peaceful, easy, has insight, and is cooperative. Second, you may get just one chance to deliver medication. For example, the patient may suddenly agree to take it, or the patient goes behaviorally out of control and you can justify an involuntary medication, and you should better give the right dose. Thirdly, and most importantly, a low dose of medication given, for example, an antipsychotic, may not really improve psychosis. It may sedate the patient, make him or her cognitively dull, and may give some side effects. For example, in an average adult, if you give somebody quetiapine 150 milligrams orally, it does have a sedating effect, but it does not have much of an antipsychotic effect. The patient will wake up still psychotic. Similarly, benzodiazepines, if underdosed, can lead to maybe no improvement, but maybe some paradoxical disinhibition and further aggression. So the best thing, in summary, is to give the highest, safest dose to bring significant relief, reduce the need for repeat medications, reduce the total time to recovery, and lastly, even if it sedates the patient as a side effect, he or she will wake up feeling a lot less paranoid or psychotic and thus being treated. Let's make some groups. The first group being the acute confusion and delirium group, the other one intoxicated states, the third one a psychotic presentation, and the unknown. Let's further divide the acute confusion and delirium one into two. One where there's evidence of withdrawal and one where there's no withdrawal. In the intoxicated, divided it into two again. One is intoxication by a stimulant such as cocaine, amphetamine, MDMA, and even include the hallucinogens such as LSD, psilocybin, and mescaline in this group. The other subgroup would be intoxication with a depressant such as alcohol, barbiturates, or benzos. The third group, as we know, is the psychiatric illness group where schizophrenia, mania, or depression with psychotic features are presenting, both paranoid or the bizarre type. And then the final one where you have no clue as to what happened. Now notice the treatment approach. The withdrawal delirious person, the intoxicated by stimulants person, and the unknown group is best treated by benzodiazepines. Very simple. The other delirium group where there was no evidence of withdrawal, or the one who was intoxicated by a depressant, and the one who's presenting with psychosis are best treated by antipsychotics. You can do some additional support in which you can add the other group, which is add either an antipsychotic or a benzodiazepine as needed. For example, take a look. In cases where you have a stimulant intoxication such as methamphetamine, you may end up adding a little antipsychotic after you've given the benzodiazepine. And on the other side, for example, in a psychotic presentation, you have given an antipsychotic, you can supplement it with some benzodiazepine. Both of them are appropriate approaches. As far as doses are concerned, here's this table that will show you the doses that you can use for both oral and IM routes for various indications. Notice that FDA has never really approved haloperidol for agitation, even though it's the most commonly used medication for agitation in psychosis, alcohol intoxication, dementia-related agitation, and ICU agitation. All of this information is available on the web and in the databases of UpToDate. Let's take a look at the risks associated with benzodiazepines. The most important side effect is sedation and respiratory depression. With antipsychotics, both first generation and the second ones, also called atypicals, we have some side effects that are similar and then ones that predominantly belong to one of those classes. With both generations, you run the risk of prolonging QTC and inducing torsades. QTC's acceptable upper limit in males is 450 and in females 470 milliseconds. Females and older folks are more at risk of increase of QTC. Other risk factors associated with prolongation of QTC are uncompensated heart failure, bradycardia, recent cardioversion, congenital long QT syndrome, and low potassium, calcium, or magnesium, and compromised liver function. There's some other risks shared by both types of antipsychotics as well, such as sudden cardiac death in patients with dementia. Other side effects include seizure threshold lowering, which is worse in olanzapine and clozapine, akathisia, which is motor restlessness, is generally bad with the first generation, but among the second generation, remember, risperidone and aripiprazole can be bad culprits. Also remember, agitation can be confused with motor restlessness. You may think the person is still agitated when actually you've induced akathisia with some risperidone. So you have to make sure you can distinguish between akathisia and agitation. EPS is more frequent with potent first generation antipsychotics such as haloperidol, and EPS kind of leads eventually to NMS as well. EPS responds best to anticholinergic and if severe to benzodiazepines, whereas akathisia responds much better to beta blockers. Tardive dyskinesia and metabolic syndromes are long-term effects, so I would not worry about them in a setting of acute agitation management. So let's summarize. The use of antipsychotics and benzodiazepines. Antipsychotics good when you have delirium but no withdrawal. Good for alcohol intoxicated patients. Haloperidol especially good when you have a precipitated psychosis. And remember not to use it when you don't know what caused the problem, or if you know that something like cocaine is involved where it has affected cardiac function and may even put people at risk of hyperpyrexia. Benzodiazepines are good for withdrawal, for stimulant intoxication, and when you don't know what's going on. Avoid if too much sedation has already happened, and watch out for respiratory depression. Do not use in delirious patients, they will get more confused. Similarly, elderly and children will become more disinhibited. Do not use IM benzo with IM olanzapine within 2 hours of each other. Now coming to the next point. These are some things that I've collected that are either evidence-based or experience-based. IM haloperidol and IM lorazepam together are better than either one of them alone, especially in alcohol-intoxicated patients with agitation. Lewy body dementia. Traditional antipsychotics and high doses of atypical antipsychotics will worsen the patient, will be more confusion, more hallucinations, more autonomic instability. Lower doses of atypicals may work, and they too may not work. Droperidol, often underutilized, is a good medication. It's equal or better in safety when compared to haloperidol. It's fast but short acting, and it is so potent that there's lesser chances of repeat medications. Quetiapine and clozapine, although not approved for agitation but work very well, quetiapine is quite commonly used. Both of them cause orthostasis and increase fall risk. Inhaled loxapine shows promise, but you really need a cooperative patient and you need bronchospasm support. Midazolam, not approved for agitation by FDA. However, very useful medication, best when you don't know what's going on, what caused the agitation, and there's severe agitation. Can make people very sedated. Often psychiatry professionals complain that the patient is still not alert enough to give them any response and cannot engage with them. Depakote. Depakote loading can be a helpful thing, especially in patients where disinhibition, manic excitement, and agitation is prominent, and for some reason you cannot use antipsychotics. It takes long, so when a patient is known that he or she will hang around, use it. Chlorpromazine is often underutilized, very effective in controlling agitation and behavior in younger folks, and those with intellectual disability and severe personality issues. Catatonia. Remember, both catatonic mutism and excitement will get worse with antipsychotics. Use benzodiazepines. Beta blockers and clonidine are often underutilized. Very helpful in panic, PTSD states, or anything with autonomic arousal. Remember, beta blockers are the treatment of choice for akathisia. Melatonin is often ignored, but it requires to be given at least 10 milligrams to help to provide at least reasonable sleep. Guanfacine.
It also has been used for anxiety control, has also been used in ICU delirium and in self-injurious behaviors. Studies have shown that to be helpful in Prader-Willi related self-injurious behaviors. MAT medications such as buprenorphine and methadone, you should think of them. They're often underutilized and somehow part of the stigma profile. Dexmedetomidine or Precedex is also another choice for severe delirious states and where the patient is absolutely unable to engage and is agitated, especially used well in alcohol withdrawal delirium in conjunction with benzodiazepines. A good takedown is which is planned and rehearsed, is quick. When it starts, the hands-on thing, and when it ends with the immobilized patient, it's very fast. Sometimes there's not even a struggle. A good show of force, which is preferred to be used as the new lingo is a good show of support, whether it's a correct lingo or not, or it's only politically correct. You know, a reasonable team approaching empathically but firmly can actually get a patient to agree to go in restraints without actually even a tussle. And then a good takedown should have no injury. A complicated takedown is usually an unplanned one that nobody was prepared for and it had to be done. And then it goes on for a long time, and it's usually a difficult, nasty struggle. And sometimes there is use of devices, for example, taser or some other things like pepper spray. These are complicated takedowns. Now, a couple of important things about takedowns. How to prevent that is through teamwork. You need to have everybody involved. The physician should be there, or the provider should be there. The nurses should be there, so the clinical team should be there, and the security team should be well trained. Remember, we need about 4 people. Less than 4 will have a high likelihood of a complicated takedown. The other important thing is prolonged endless dialogues between staff and the patient. So the staff is trying to avoid a takedown and the patient is not backing down, and there is a long dialogue going despite tag-outs, rephrasing of the argument, or providing alternatives. Prolonged endless dialogues often end up in a more vicious takedown at some point. So we have to have a little bit of an idea how long we are going to struggle at an argument that is going nowhere. Lastly, you can have some strange situations where resources don't match the need. An example would be when you get somebody who is extremely strong and is potentially capable of inflicting a serious injury. In such cases, we need to understand that we must do some due diligence. First of all, our due diligence includes safety of all. We have to make sure we don't let our staff get hurt. We must alert the administration and alert the local police. We should get them to come, and we should stall any engagement until we have police available. Sometimes, if it's not possible to stall, we should facilitate the patient leaving the premises, as the risk is having a serious staff injury, and that's not an acceptable risk. So we're going to talk about restraining patients and documenting them in a justified way. Remember, CMS looks at personal holds, lock seclusion, and physical restraints as restraints in their language, and they like to count everything in minutes and hours. So now let's go ahead and talk a little bit about how do you actually use the language for severe aggression. Remember, they're pretty much the same thing, but these are the 3 ways that you can document. There was ongoing violence, or the patient was disturbing the milieu, traumatizing other patients, or de-escalation failed and the BVC score was going up. So this is one way to think about them. Then you have sometimes a situation where you have a patient who is extremely unpredictably violent, and you may have to choose using scheduled medications as a preemptive attempt. And how do you justify that? If you have history of severe unpredictable violence in the past, that is a reason to consider that. So if a patient comes in violent or threatening, and in the past he has a history of extreme, severe, unpredictable violence, you need to do something now as prevention. Sometimes when you have a patient who's rapidly and severely deteriorating without any treatment, you will have to consider that in the interest of the patient. And then finally, you have the dangerous Arnold Schwarzenegger-like patient. So remember that these are the words you can use for documentation. Now let's talk about the concept of remaining in charge. Being in charge is a tough, difficult juggling act. You have to be very clear about a lot of things. For example, when you engage with the patient, you have to keep your empathy. You need to get the patient to participate. And patient's historical experience, such as a good experience with a certain medication, is a valuable information that should be taken into serious consideration. However, you can have some other situations, and the other side of the juggling is that you need to look at the current clinical needs. You have to look at all other negotiations the patient is asking for, as long as they're not opposed to the clinical indications. So things that are not clinically indicated may not be in the best interest of the patient. So you have to make sure that you deal with those appropriately. Now, you can have some patients who will come in and create undue demands. Sometimes people with personality disorders or people with intoxicated states may say something like this: if you don't give me my Xanax, I will break the door down. Or, nothing can help me except a large dose of Klonopin. Or, I need my Adderall or I won't talk or cooperate. Now, these are examples where patients start dictating clinical decisions and showing that they are negotiating, but then they're asking for something that in your mind may not be clinically indicated. If there is clear indication, go ahead and give them. Now, they may have some negotiable needs that are more appropriate. So, for example, I need to get my clothes dried up for me, please. They're wet. Or I need a sandwich. Now, as long as none of those are opposed to a clinical situation, you can go ahead and accommodate them. But when they ask for something clinical and coerce you into that, that will have to be dealt with a calm, clear, but a firm attitude, where you will offer them options. Instead of saying that you are asking for Klonopin as your problem, what about me saying that your anxiety is a problem and let me treat the anxiety with the best approach that I can in this place? So often patients will use their end goal as the problem rather than the issue that led to that end goal. So that's a helpful way of approaching these patients. You remain quite clear and firm and supportive, but you do not get coerced by their clinical dictates that are not indicated.
So we will conclude now. Thank you very much for listening to this long talk. At the end, I would say that with the proper skill and awareness, managing a very difficult and aggressive patient should not be that difficult. If you have a good team, you talk to each other, you can do it. Yes, the resources can be a constraint and maybe beyond your paycheck, where you have to bring in other administration, and it can even go beyond that. So I hope this was helpful. Please feel free to send me any comments or questions. My email will be at the end of this. And have a very good day.